topic is aptly orthobiologics of the knee. So I think first and foremost, it's really important that whenever talks about orthobiologics, you have to disclose if you have any relevant disclosures. And thankfully, I have none for this particular talk. So orthobiologics in the knee, and I think we need to answer 4 questions. What is it that I currently use? What are the products that I can use? What are the products that I may be able to use? And what I am looking forward to use? And I think it's pretty relevant that we answer all these 4 questions because it really sets the tone for things to come in the next decade or 2. So broadly, you can classify orthobiologics into autologous products and allogenic products. If you look at the autologous products, essentially you have chondrocytes, you have PRP in its various forms, either leukocyte rich or poor. You can have bone marrow aspirate with or without additional stimulation like Neupogen. You can use adipose tissue either in the form of vascular stromal factor or the mesenchymal cells. And you can also have various formation of autologous conditioned serum, which could be either based upon the particular lab or they could be at the point of care, so as to say. The allogenic orthobiologic products that we have available are the various tissue-specific MSCs. You have the amniotic line of products, especially with the amniotic stem cells or the various amniotic fluid products. And last but not the least, you have the various scaffolds, which will consist of either a micronized or minced chondral tissue, and you could have chondral and osteochondral discs. So essentially, it's not going to be possible for me to touch or discuss each and every one of them, but I probably picked up few which I felt were important, especially in the Indian scenario, which could have relevance in our day-to-day clinical practice. So these orthobiologics essentially will work in 3 different ways. Either they're going to be useful to enhance healing, or we're going to be using them to create some kind of regeneration. And last but not the least, which is very important, is that how we can use them to modify the course of our disease. So if you look at healing, the application of healing essentially would be in ligaments, especially for the ACL or the various ligaments around the knee joint, or you could use them on the tendon in the form of various injections of PRP or BMAC, which I think have been proven quite effectively. In terms of regeneration, one can use it essentially for regenerating cartilage in the various forms of microfracture or marrow stimulation, various modalities that we have, and the improved generations of the autologous chondrocyte implantation, or we could have allograft-based products on the cartilage side. Meniscus is, I think, one area where we have to be improving in the near future. And though the current modalities of biologic augmentation such as fibrin clot are well established, I think the future is pretty promising for the newer generation orthobiologics such as MSCs, PRPs, BMAC, and certain scaffolds as well. The biggest role, I think, and the biggest application today is that of disease modification. And though in osteoarthritis, I think it's been shown to exert a good role, the role in subchondral bone yet seems to be proven. And I think that is where we need to look out for that space. So this is a very good, I think, diagrammatic representation that I picked up from this article that was published in Journal of Orthopedic Research. And essentially, it just shows the cellular response to any form of injury or insult. And what you can see here is that it goes through 2 phases. The first phase essentially is that of cell death and inflammation. And then we have the second or the late phase, which is essentially the phase of matrix formation. In between both of these, we have the intermediate phase, which is essentially a swinging balance between the catabolic phase of tissue damage and the anabolic phase of tissue repair. And it is our capacity to use this particular modality which sets the tone as to what exactly we can use in our clinical processes. So essentially what you can have is that we can use the early phase when we're looking at cartilage lesions, when we're looking at ACL repair or early osteoarthritis, and we can use the late phase to modulate our results, especially with chronic pathologies such as tendinitis, tendinopathy, or muscle disorders in particular. So let's look at one of these one by one. If you look at articular cartilage, and what we have on the side of your screen is essentially the pyramid of evidence that we have. I think we have been shown pretty well that articular cartilage has shown all the 5 levels of evidence. We've been well established with techniques of marrow stimulation. We've been using marrow stimulation with scaffolds. There's been good evidence now that is coming out on particulate cartilage as well. ACI has evolved over the last couple of years or decades through its various phases. And definitely what seems to be really promising is the cell-based tissue culture with 3D printed scaffolds, which is something that we are all looking forward to. So it all started off essentially with scaffolds. The first scaffolds were the biphasic scaffolds, and then came the triphasic scaffolds. But unfortunately, these scaffolds did not really work too well. They did not perform as well as what cartilage wanted us to do. And I think probably the future lies on the third picture, which is there on your screen to your right. We're essentially looking at scaffolds in which we impregnate cells, and these are then transferred to the joint. So that is probably one area where one should be looking out for a good response of therapy in the days to come. Particulate cartilage is very promising. I think its most important benefit is that it is available off the shelf, so as to say. So what we have, which has been there for quite some time, is the de novo cartilage or the allogenic juvenile particulate cartilage. Unfortunately, the source of this allogenic cartilage is pretty limited. You have to have small children, who are cadaver donors, which are then amenable for this. And with the advent of the new autologous particulate cartilage now, which is now being pushed by a couple of commercially available kits, I think the results are still to be seen. They're probably still in their sort of fourth phase of evidence, where we have some amount of controlled non-randomized trials, and we still await the results with the help of PRCTs, and then later on have systemic evidence based on the same. ACI has gone through various phases of evolution. It all started off essentially by culturing chondrocytes in the lab for about 2 to 3 weeks, and then bringing them back to the operating room, essentially implanting them as an open procedure with using periosteum. Later on, it became more fancy. You had those cells that were laid on membranes, which were then just stuck down with fibrin and thrombin glue. And now I think we are quite fortunate enough to have probably the 5th generation of ACI, which is essentially a cell-based ACI technique, wherein we use cells that are suspended in a matrix of fibrin and thrombin, which tends to coagulate and form clot quite easily on the defect that has been prepared. And I think it has stood the test of time and has shown consistent results.